Good morning. My name is Ahmed Almustafa. I'm a heart failure fellow here. I'm fine. Just Dr. Nathan is in the panel, Dr. Karen from me, and Dr. Jomian is there. So today I'm going to present Impella support is not always straightforward. So this is 70-year-old male with past medical history of coronary artery disease, test post-PCI to LAD. He's on Plavix, hypertension, hyperlipidemia, diabetes, chronic kidney disease, and morbid obese. He presented to outside hospital with chest pain for 3 days duration, got worse 2 hours prior to presentation over there. On a presentation, his blood pressure was 170 over 100. He was setting 90s on high flow nasal cannula. He was tachycardic with heart rate of 200. His initial EKG did show wide complex tachycardia consistent with VT. He was cardioverted, and post-cardioversion, his EKG did reveal ST elevation anteriorly, and patient was taken to the cath lab. His angiogram did reveal severe coronary artery disease involving distal left main to LAD and severe disease in RCA mid to distal. The decision at that point was to place a balloon pump and referred him for bypass surgery, giving his anatomy and the clinical presentation. His echocardiogram at outside hospital did show EF of 25 to 30%. Swan catheter was placed on the second day, which showed normal PA pressures with normal cardiac index. He had episodes of VTs over there that required cardioversion. He was on amudrep as well. In day 4, he was vitally stable. Labs showed hemoglobin of 10. Kidney function was okay. Creatinine slightly elevated, 1.4. He was on heparin, nitrodrep, amu, and balloon pump. A plan for surgical intervention in 2 days due to low platelets aggregation as patient was on a Plavix. In day 5, unfortunately, he developed severe chest pain. He was taken to the cath lab for high-risk PCI with Impella support. Then 14 sheath was placed in the left common femoral artery, and pigtail was used to cross the aortic valve. LV systolic pressure was 112 with EDP of 17. Impella CP was inserted through left common femoral artery, and that time at P9 with flowing 2.5 liters. From here, things turned south. Patient became bradycardic with heart rate in 20s, hypotensive with MAPS in 50s. He was started on pressors, and transvenous pacemaker was placed. His angiogram did not change, which showed severe left main disease. The cardiologist over there was worried about hypotensive, and he did like angiogram of the both femoral arteries, which showed no extravasation. Also did an aortogram, which showed no extravasation as well. Echocardiogram was done in the cath lab, which showed large pericardial effusion, and patient underwent pericardiocentesis. Despite that, patient was still hypotensive, so LV gram was done, which showed an EF of 20%, large anterior apical aneurysm, and no apparent extravasation. But if we look closely, we can appreciate small amount of contrast in the pericardium and around the tip of the impella. This extravasation was not noticed there. Patient was giving protamine and multiple blood transfusion, started on drips, and he was transferred to our institution for further evaluation. When patient arrived to our ICU, he was intubated, hypotensive with MAPS in 40s, and multiple pressors, very high doses. Bedside echo did reveal large pericardial effusion with minimal pericardial drain. He was also non-pulsatile, and he underwent ACLS for 2 minutes. He was in severe cardiogenic and hemorrhagic shock. His lactic acid was 10, and shock liver as well. Dr. Salas was the lucky surgeon in that night. He took patient to the cath lab, to the OR. Patient underwent a sternotomy, and he was found to have LV perforation from the impella, as we see in this video. He underwent LV repair, and then he was placed on central ECMO. And this slide for the LV repair. His postoperative course, he was on central ECMO, multiple procedures. He required multiple blood transfusion due to coagulopathy. We could not put him on heparin, and he was started on CRT for acute kidney injury. In day 2, patient became unresponsive. His CT print showed finding consistent with acute ischemic stroke. He was still requiring blood transfusion. He was having shock liver. Unfortunately, he did not make it, and patient and family decided to make him comfort measures. So from my presentation, take-home messages. In the setting of friable myocardium, any intraventricular device should be placed cautiously. And diagnostic LV gram in the setting of Impella could be sometimes challenging because the fact that LV is decompressed and does not generate normal systolic blood pressure, and the Impella pumps the contrast directly into the aortic root, bypassing the LV ejection. And thank you.
I guess the question is it the bowler or the shoes? I don't think you can blame the Impella as much as maybe aggressive pushing the catheter, being on P9. That's really tricky. I wonder why they didn't just take the patient for, sooner. But good management. But it sounds like it was no way going to win this one.
Yeah, we're not sure about the details there in the cath lab, but
we wanted to present this case because there's a lot of Impella put in the outside facilities. So when you have sudden surge of Impella insertions, you're going to find these kind of problems. I think that's where I think the panelists, I would like to comment on how to approach this, because when you do a shock initiative, availability of these devices are there in secondary level centers. So there's going to be a lot of patients coming this way.
Can I, it's positioning. I know it's a drag again. I mean, if you look, I know you're not going to go back, but if you just take a first look, you see that the Impella ends not in the apex, but it ends somewhere else. Something has gone wrong with the introduction, right? And sometimes, again, yes, I said, when you get this wire in the LV, you think, oh, it's my first step, and then you have the second, oh, it's my second step. But you really need to understand if the wire really is into the apex. If it's free, then sometimes you can even, there are some thoughts that if you then have a wire in and you could put in a normal pigtail just to be sure whether it is in, but even that pigtail can be entangled behind one of the chordae. So it is always a thing. And then of course you really have to, if the wire is outside the ventricle, then the apparatus will follow. And if you are strong enough, then you will push it through the ventricle. I have not been able to do that yet, but perhaps it will come.
Neither I have not done that one yet either. But I would definitely amplify. Everybody in the audience should remember that the position of the wire, having put these in, that is the most important thing to take that time. Because we're always scared. A lot of times the patient will have arrhythmias as well when the wire goes to the apex. But having it around, the way you start is the way you finish, probably with every device.
Just one question for the interventional people that put these in. When we do caths, right heart caths through the left IJ, we use a balloon-tipped method to go ahead and let the balloon guide you. Is there any place for that within the setup of the Impella insertion? I was just wondering if you could put a catheter to know where you're. Oh, what am I thinking? Yeah. That's right.
No, but actually, one of the methods to do it.
Big problem.
Yeah, one of the methods. It's a little bit cumbersome, and especially in severe shock, you will not manage. But you can, if in patients who undergo elective high-risk PCI, the valve opens up very well, of course. And if you use a normal pigtail and you flip it just through the valve, then you're always sure you're right, because it will go automatically, and then the positioning is over. But any other type of insertion with the catheter, with the directed catheter, then you're always unsure. And you need to be sure before you leave it in. Just pull it.
Quick comment.
If it opens up, it's not good.
I was the surgeon involved in the case, and to be fair, this is my perception of the case. It was not far, the perforation was not far from the apex. It was in the inferior wall. I think what happened, and this is what I believe, is, they went back to do this procedure 5 days after the initial STEMI. So I think at that point, histologically, probably there was a lot of necrosis and a lot of macrophage eating everything. There was no initially any sort of fibrosis. So it was a border ventricle, because even, thank God, when I was there and I saw the tip, before trying to pull it to position, I decided to put the felt strips before tie or anything, and then I pulled a little back the impella from the groin, and it came out of the ventricle immediately. And then I tied the suture. But this ventricle was, and after that I went on crash on pump, and I have to put a lot of repair stitch, and the ventricle was a butter, everything. So what I believe is, it was not far from the apex, and with this weak ventricle, you just went through something that probably was not preventable there.
But it has to be on the initial insertion.
Yes.
It has to be on the initial insertion, otherwise the pigtail would never have gone through the...
Agree.
Yeah.
That part I do agree. But the impella kept flowing until it got the tamponade, Because if you see, after I evacuated all the clots that I took the video, the support of the patient was perfect. I was in my mind, I was thinking, I just pull a little back, tie the suture, call for the day.
You mean it's a good positioning that way?
I think part of the thing in this case is this patient presented 72 hours late. Second, this was the posterior MI. If you look at, there's large R waves in V1, V2 with the concurrent ST depressions there. So it was the inferolateral wall. And on the imaging, that's exactly where the LV pigtail was placed for the impella. So you were pretty much at the site where the patient has been having necrosis for 72 hours, and then any aggressive manipulation that site is basically going to lead to perforation. I want to open up one question. What is the standard imaging that you guys are doing? Is it daily serial echoes? Post-impella, I know not every site does daily serial echoes. I've been doing the same, just not only looking for positioning, but also looking for MR, as we've seen today, and then also TR, as we saw in that last case. I think there was some coagulopathy that was ensuing right after. And then maybe in this case, if we had done daily serial echoes, even without considering the need for repositioning, the tamponade would have been picked up earlier. Maybe you would have not been in dire straits as much.
I mean, we don't do it like in daily basis. We just do it like when we expect something going on. But this case, all things happen acutely. Like this happened in the cath lab when the echo was cold and showed like a pericardial effusion. But usually, like in the ICU, we don't do it in daily basis. We just do it when there is, question about impella position or hemodynamically unstable or something like that.
I think you should do it every day.
I had a question. I can't help but wonder if, in fact, the reason the patient might have had chest pain on that day was that he was having essentially a sentinel bleed. We talk about sentinel bleeds with, aneurysms, and I've seen a couple cases, and I'm sure all of you guys have as well, where a patient comes in with, for example, inferior MI, and, maybe they develop a little pericarditis, then they develop sort of acute pain and get a little bit of an effusion, but then they don't progress to full tamponade at that point. And then if you act and recognize it, then you can potentially get them to the OR because it's actually a subacute early rupture. And I had a really nice case that I was trying to get someone to write it up, but I don't think they published it, where you can actually use echocardiographic contrast, and you can visualize the microbubbles in the pericardium, and that was what we used in that case. And that was actually the first time, maybe the only time I've ever been able to convince a cardiac surgeon of anything. After 20 minutes of explaining what it meant, but not that you guys aren't smarter than me, but it takes a while for me to get to your level. But that was, I think, a big save. And so I don't know what happened in this case, but I do wonder.